And so today I'm going to speak to you about hereditary cancer, and I'm going to focus on hereditary breast and ovarian cancer as a paradigm. But keep in mind that we do see patients for all different types of hereditary cancer: colon, uterine, melanoma, thyroid. Almost every type of cancer can be hereditary. And so today what we're going to discuss, a brief review of genetics and genetic testing. We're also going to go through a few family pedigrees from families who've been through this process. And I think those will really help illustrate the salient points. We're also going to talk about the psychosocial issues, which really is our focus today, as well as the risks and benefits of genetic testing. And so it's very important to keep in mind that only 10% of cancer is actually hereditary. So most people who have cancer of any form, most of those people do not have a hereditary form of cancer. But we're going to focus today on the people who do. And we're talking about people with germline mutations. And so a germline mutation is a mutation that's usually inherited either from the mother or from the father. 50% of the time, it's from the father. Keep that in mind. But these are germline mutations that are present from the time that person is a fertilized egg. And as that fertilized egg divides and divides and divides to become that person, this mutation is present in virtually every cell of their body. I'd like to distinguish that from somatic mutations. And somatic mutations are getting a lot of attention these days because, as you know, when tumors are removed and sent to the laboratory, they're now studied. And so one of the tests done is HER2, for example. So people will often call our clinic and say, I want to come in, I carry a genetic mutation. But when we ask them what the mutation is, they say, I have the HER2 new gene. That is actually a gene that is looked at in the tumor itself. The person was not born with that mutation. That mutation is not present in their ovaries or in their testes, so they're not going to be passing that mutation on. It's a somatic mutation confined to the tumor. That is not going to be the focus of our talk today. And so these are the risk factors that can help someone understand if he or she may be at increased risk for a hereditary form of cancer. And the first question is there a very early age of onset? So for breast cancer, that's anyone diagnosed at 45 or younger. And for colon cancer, that's anyone diagnosed at 50 or younger. If one person in the family has an early onset cancer, even in the absence of any other family history, that person is automatically at increased risk to have a hereditary form of cancer. The second risk factor makes complete sense, right? And that's multiple affected family members on the same side of the family. So if many people in the family have had colon cancer, of course that's going to increase our suspicion that it may be hereditary. The third risk factor is quote-unquote related cancers in the family. And by that, I mean cancers in the family that are known to be caused by the same genetic mutation. So one cluster that we look at is breast, ovarian, and pancreatic cancer. Another cluster is colon, uterine, and ovarian cancer. And so it's important not to only know if other people in your family have had the same kind of cancer that you've had, but have there been other types of cancer in the family? Number 4 is multiple primaries. So any time we see a single person who's had multiple primary cancers, not a breast cancer that has metastasized to bone, but for example, a woman who's had both breast cancer and also ovarian cancer, or someone who's had 2 separate colon cancers, or colon cancer and uterine cancer, or colon cancer and ovarian cancer. That obviously increases the chance that that person has an underlying genetic susceptibility to cancer. The fifth risk factor is unusual presentation. In this case, we're talking about any male who's had breast cancer. We don't usually see men with breast cancer, but when we do, it's a very significant risk factor for hereditary cancer. Number 6 is ethnicity. You may know that there are certain genetic diseases that are more common in every single ethnic background. It just so happens that people of Jewish ancestry are at increased risk for hereditary breast and ovarian cancer. So Dr. Miller can tell you that one thing that I often push at our breast conference is this patient of Jewish ancestry? And a few years ago, when I started asking that question, people would look on the intake sheet for the patient, what religion they practiced. And as we know, that is not a good marker. Other people would say, oh, that last name is Black, that doesn't sound like it's Jewish. No, not a good answer. So we need to ask people, do you have any Jewish ancestry? If the answer is yes, they're at increased risk for hereditary breast and ovarian cancer. Number 7 is pathology. And I have this risk factor in italics because it's a developing area of risk assessment. For example, we know that medullary breast cancer, a rare type of breast cancer, is overrepresented in these hereditary families. We're beginning to suspect that patients with ER, PR, and HER2 negative breast cancer, sometimes called triple negative, are also overrepresented in this cohort. We know that patients with mucinous ovarian cancer and borderline ovarian cancer are less likely to have a hereditary form of cancer. So pathology is going to be a really good indicator for us in the future. The mutations I'm going to be speaking to you about today are all passed down in this pattern of inheritance, which is called autosomal dominant. And you can see in this pedigree where the squares are men and the circles are women, that this represents a couple. And these lines down represent all of their children. And so if the woman, or the man, but if either parent carries a mutation, each child has a 50-50 chance to inherit the same mutation. If one child does not inherit the mutation, then in that little branch of the family, the mutation stops and cannot be passed down to the children. But if a child does inherit the mutation, then his or her children have a 50-50 chance. And so this is a sporadic event with each pregnancy. You could flip a coin 5 times and get 5 heads or 5 tails. It's the same with autosomal dominant inheritance. And in fact, I had a family with a hereditary form of colon cancer, and there were 5 adult siblings. And I told them about this 50-50 inheritance pattern. And all 5 adults were tested, and they all came back carrying the mutation. And so then they didn't believe me after that. And they said, in our family, it's 100%. And I said, no, really, it's just an odds ratio. And so when the grandchildren came in for testing, some of them tested negative. And so they said to me, oh, Ellen, maybe your little theory is correct. So actually, this really isn't my personal theory. This is how the mutation is passed down in families. So the first gene that I'd like to talk to you about today is BRCA1, standing for breast cancer 1. You'll hear this gene bastardized as BRCA1. That's not the correct name for this gene. It's BRCA1. BRCA1 is the name of the test developed by a company. In retrospect, this gene should have been called breast and ovarian cancer 1 because all women who inherit a mutation in this gene are at risk for both forms of cancer, even if only one of those types of cancer has been seen in their family so far. We know that, as I mentioned, women are at increased risk for both breast and ovarian cancer, and that men who carry a mutation in this gene are at increased risk for prostate cancer. This is a schematic drawing of the gene showing that thousands of mutations are present in the gene from families from around the world, every ethnic background. And so we do see it in every ethnicity. The second gene, BRCA2, is actually a completely different gene on a completely different chromosome. But women who inherit a mutation in this gene also have a high risk of developing both breast and ovarian cancer, and men have a slightly increased risk of developing prostate cancer. We also see an excess of pancreatic cancer in these families, as well as male breast cancer. And this again is a schematic of the 2 genes. And as I mentioned, these different mutations can be seen in families from around the world. But there are 3 mutations, 2 of them in BRCA1, and 1 here in BRCA2, that are overrepresented in families of Jewish ancestry. And we know, in fact, that 1 in 43 American Jews carry one of these 3 mutations. 1 in 43. That's compared to about a 1 in 500 population prevalence in the United States for non-Jews. In Jewish women who have breast cancer, 1 in 10 carry one of these 3 mutations. If it's an early onset breast cancer, that number goes up. If it's ovarian cancer, a Jewish woman with ovarian cancer, about 4 in 10 of those women will carry one of these mutations. So if someone carries a mutation, what is the big deal? How high is their risk? For breast cancer, we know that the population risk is about 11 to 13%. That's a lifetime risk in the United States for breast cancer. If a woman carries a BRCA1 mutation, however, her lifetime risk is between 55 and 85%, so a marked difference in risk. And with BRCA2, it's similar. We also know that that woman has a higher risk of developing a second breast primary. And if you think about the underlying biology, this makes perfect sense. Because if someone carries one of these mutations, again, they've carried it from the time they were a fertilized egg. They either got it from their father's sperm or from their mother's egg, and so it's in that fertilized egg, and as that egg divides and divides and divides, this mutation is present in all of those cells. So if a woman carries a mutation, it's present in all of her breast cells in both breasts. So her risk to develop a new primary breast cancer, either in the same breast or in the other breast, is much higher than it would be for the average breast cancer survivor. For the average breast cancer survivor, her risk of a new breast primary is about 1% a year, usually topping off at about 15%. But for someone who carries a BRCA1 mutation, it's up to 65%. And for BRCA2, it's about 50%. With ovarian cancer is a fairly rare cancer in the general population with a lifetime risk of 1 to 2%. But in BRCA1 carriers, you can see that that risk is much higher, and it's also higher with BRCA2. And so other cancers that we now know are seen in BRCA1 and 2 carriers include male breast cancer. With BRCA2, the lifetime risk of male breast cancer is about 5 to 10%. And for the average man, it's much less than 1%. In fact, about 1 in 1,000. For prostate cancer, that risk is also increased. And for pancreatic cancer, which is a rare cancer in the general population, particularly with BRCA2, you can see that the lifetime risk is 4 to 8%, so higher. And so let's review some of the options for breast cancer risk management for a woman who learns that she carries a mutation in either gene. There actually are 3 categories of options. The first is surveillance. And so these women, if we know that they carry a mutation, they don't get their first mammogram at age 40. We begin surveillance at age 25 or 10 years before the first diagnosis in the family, whichever occurs first. We also follow them with breast MRI, with frequent breast exams, not only by their primary care physician, but also by a breast surgeon. And those are their surveillance options. We are hopeful that surveillance, early and aggressive surveillance, will help to detect these cancers at an earlier, more treatable stage. But the next 2 categories of options have to do with reducing the risk that cancer ever occurs. So the first option is chemoprevention. Chemoprevention, not to be confused with chemotherapy, is when a healthy person takes a medication to reduce their risk of ever getting cancer. So in this case, the drug of choice is tamoxifen. Some of you are probably familiar with tamoxifen as a treatment for breast cancer. We now also know that healthy women at high risk who take tamoxifen can reduce their risk of getting breast cancer in the first place by as much as 50%. We do not yet have the data on how effective tamoxifen is in BRCA1 or 2 carriers, but we're hopeful that it will be quite effective. The third option is prophylactic surgery. The prophylactic surgery of choice here is bilateral mastectomy. We do have data now that show that this surgery reduces the risk of a new breast cancer by more than 95%. And I know that when I first entered the field and genetic testing was a brand new option, and this was only 10 years ago, that prophylactic surgery was really considered to be a crazy option. And when I was talking about this as an option to colleagues at all conferences with other healthcare providers, I was amazed at the emotion that came out of the crowd, that this is mutilation of women, why would you even bring this up? And the lesson that I learned about prophylactic mastectomy actually came from a patient. And she was one of my first patients. She was 35 years old at the time, and genetic testing had literally just come out. So she was the first patient that I tested. And her mother had died of breast cancer, as had her grandmother. And so, of course, this first patient I offered testing to tested positive for BRCA1 mutation. And I couldn't believe it, to be honest with you. I mean, we had so little information, so little data, and I was up all night thinking about how to tell her this and what I would say and what I would offer her. And I had this very measured approach. I wanted her to see a psychologist for 6 months before making a decision, and then we could talk decisions. So anyway, I went in and sat down with her and told her she carried this mutation. And I must have looked so worried that she leaned across the table and held my hand and said, "It's going to be okay." So that tells you something right there. And I said to her, listen, we have surveillance options. We're going to take this step by step and work with the psychology. And she said, nope, I'm having a bilateral mastectomy, and I'm doing it by the end of the month. And I said, oh my gosh, let's slam on the brakes. Let's think about this. And she said, the decision is actually quite simple for me. My grandmother didn't make it to my mother's high school graduation, and my mother didn't make it to mine. I have 2 little girls. I'm going to be at their high school graduation. I'm going to be at their weddings. I'm going to know my grandchildren. This is the easiest decision I've ever made. And she had that surgery that month. And she had immediate reconstruction, and she's alive and well and cancer-free. She has never developed cancer, and she's very happy with her decision. So I've learned to respect that these decisions are individual decisions to be made by each patient, him or herself. You'll see that the options for ovarian cancer risk management are quite similar, although the actual options in each category are different. For surveillance, we do have a blood test called CA-125 and also transvaginal ultrasound. And we also have some promising markers that we hope someday will be useful in detecting ovarian cancer at an early treatable stage. But today, in the year 2007, we do not have good ovarian cancer surveillance. We have nothing that has been proven to detect this cancer at an earlier or more treatable stage. Chemoprevention is available in the form of birth control pills, believe it or not, and we do know that the use of birth control pills significantly reduce the risk of ovarian cancer. If they increase the risk of breast cancer at all, which is somewhat debatable in the newer lower dose pills, it seems that the benefits outweigh the risks for most unaffected female carriers. Prophylactic surgery in this case is removal of the ovaries and the fallopian tubes. Not only does it reduce the risk of ovarian cancer by more than 90% in women whose pathology comes back after the surgery completely clean, it also reduces their future risk of breast cancer by more than 50%. And of course, this is because it reduces their estrogen levels significantly. And so now that we've talked, that didn't really translate well. So I'll tell you about this pedigree. This is a mother and a daughter who, unfortunately, within the same month, the mother was diagnosed with ovarian cancer and her daughter was diagnosed with breast cancer. The grandmother had both breast and ovarian cancer, and the great-grandmother died of breast cancer. And so, as I mentioned, both the mother and daughter were diagnosed within the same month. They both went through their surgeries and their treatments, and they came in 6 months later, which was unfortunate because the daughter had chosen to have a lumpectomy, chemotherapy, and radiation. And not surprisingly, we learned that there was a BRCA2 mutation in this family. When the daughter learned that her risk of breast cancer was high, her risk of a new breast cancer in either breast, she opted for a bilateral mastectomy at that time with reconstruction. And because she had already received irradiation to the breast, it made her reconstruction more difficult. So we always urge people to have genetic testing before making a surgical decision, and also before radiation, whenever possible. This is a second case of a young woman who had been diagnosed with breast cancer at age 35. And then 5 years later, she was just being seen for her routine checkups, and her oncologist said, you know, if you were diagnosed today with breast cancer, we would have referred you for genetic counseling, and I wonder if you should still go now. And she said, oh, you know, I have no family history of cancer. I think this was a fluke thing. But she decided to come in anyway, and she carried a BRCA1 mutation. When you look at her family history, you can see that her father, who died at a young age of another cause, was an only child. And she had very little information about her grandparents who lived in another country. And so actually, this woman, who we learned inherited this mutation from her dad because her mother tested negative, it's really not that she had no family history of disease. It's that she came from a very small family with very few female relatives. And so this can complicate our risk assessment tremendously. Last case. This is a woman who called me within weeks of her sister's death from pancreatic cancer. And she was calling me kind of as a last call on her list. She consulted with the gastroenterologists. They'd said if you have no family history of pancreatic cancer or other GI malignancies, you're probably not at high risk. And then she got me on the phone. And when I took the rest of her pedigree and asked about other things, it turns out that on her dad's side of the family, there was a family history of breast cancer in an aunt, breast and ovarian cancer in a grandmother, and breast cancer in a living cousin. And so I suggested that her cousin be tested for mutations within BRCA1 and 2, and sure enough, she came back positive for a BRCA2 mutation. We were then able to obtain a tumor block on this deceased sister and learned that she too carried that BRCA2 mutation. We then tested this unaffected patient, and she did not carry the mutation in the family. She was a true negative. Her rates of cancer are the same of other people in the general population. And so you can imagine, just from this short talk, the wide range of psychosocial issues that come up from genetic testing. And I'm just going to touch on a few here today. Why would I want to open Pandora's box? This is probably something going through many of your minds right now. And what do you mean I'm at risk for other cancers? Cancer is in my outbox. I've had it, I went through it, I don't want to think about it again, and I certainly don't want to talk about it again. I've been through enough with surgery, radiation, chemotherapy, medications. I don't want prophylactic surgery. I can't believe that my siblings, parents, children, and grandchildren might carry this mutation. I feel so guilty. These are some of the initial issues that come up often when someone is considering genetic testing or when they come in for their first counseling session. And now I want to talk to you about the flip side, some of these issues and how they can turn around. I'm not saying that they do turn around for each person. But the flip side, knowledge is power. I'm going to look at the cards and change the game. So if someone knows that they're at increased risk for several cancers and there's something we can do about it, either through surveillance or chemo prevention or prophylactic surgery, it actually gives the power back to that person. I don't want to ever have cancer again. Cancer is in my outbox and it's going to stay there. And genetic testing will give me the tools and the information I need to make sure that it stays there. I've been through surgery, radiation, chemotherapy. I can handle prophylactic surgery. I don't want to handle it, but I would rather handle prophylactic surgery than yet another diagnosis of cancer. Believe me, I've been through worse. That's a common thing to hear. I'm going to change the pattern in the next generation. I'm empowering my entire family. I'm working with a family right now in which the grandmother has had an early onset breast cancer. She then had a later onset breast cancer. And now in her 70s, she has ovarian cancer. This woman has been through a lot more than any one person should. And she came in, even though she's very ill from her treatment, and she had genetic testing, and we found a mutation. And I've now seen 2 of her daughters for testing, and we're waiting for their test results. But the thing that is clear is that whether they test negative or whether they test positive, this will allow us to manage their care and to reduce their risks of ever getting cancer. And so I said to this grandmother, you have given your family a gift. By knowing this information, we're going to be able to change the pattern here. I'd like to mention that there are both risks and benefits of genetic testing. There are psychological risks, as you can imagine. It can be very stressful, particularly within the first 6 months of learning this information. Discrimination is not as much an issue as we thought it would be from health insurance companies, but it is an issue with life insurance. I sometimes mention to patients that they may want to secure their life insurance before having the testing. Not sure how that would go over with the insurance companies, but that's what I say. I will say that I think one of the greatest risks of genetic testing, and one that is underestimated, is the misinterpretation of test results. Some studies have been done on this, showing that the referring healthcare provider often misinterprets the test result. It's not a simple negative, positive. And we have these testing companies that are really banging on the doors of many medical offices saying you should do your own genetic counseling and testing. And we've seen some negative side effects of that approach. So I would encourage you, if you're going to have genetic testing, to make sure to go to a provider who really knows what they're doing. In terms of benefits, there are also psychological benefits. If people test positive or negative, they know their risks and they can move forward. Some patients come in feeling like they're at risk for everything, and it's actually a relief to them to know, actually I'm only at risk for this or for that, and here's what I can do about it. In terms of medical management, you can see that a positive or negative test result would be helpful, and that it also benefits other family members. And so today I'm going to end on a few of the greatest urban myths in genetic testing that I'm hoping you can help me dispel. The first, if you have genetic testing, your health insurance will discriminate against you. We have not found this to be true. Number 2, your insurance will not cover the cost of genetic counseling and testing, and boy, does it cost a lot. It does cost a lot, but most health insurance companies will pay for it for patients who are truly at risk. Number 3, only Ashkenazi Jews are at risk for BRCA mutations. False. Most women who carry a mutation are not Jewish. They're just seen at a higher prevalence in this ethnic background. 4, you should only have this testing if you would consider bilateral prophylactic mastectomies. No. As I mentioned, that's one option. There are many others. Most of our patients actually do not consider this surgery, at least within the first 5 years of knowing their results. Number 5, you've already had cancer, so testing won't help you. It could help determine your risk of another cancer, and it could certainly help family members. Number 6, your father's family history doesn't count. Keep in mind that it counts equally. Both sides of the family history count. Number 7, you only need genetic counseling if you test positive for a mutation. Absolutely not true. And 8, if you test negative for mutations, you are at population risk for cancer. This is only true if a mutation is identified in the affected family members and then the patient tests negative for that familial mutation. So this is somewhat complicated. I'm obviously not going to be able to address individual family questions today, but I would ask you to go to NSGC, standing for National Society of Genetic Counselors.org, to find a genetic counselor near you. Or you may also go to the NCI website, and they also have a finder for cancer genetics specialists. Mommy, when I grow up, will I get breast cancer? And as you can imagine, this is one of the things that many of our survivors are concerned about. Are my children at risk? And really our goal is to reduce the risk that those children will ever develop cancer in the first place. Thank you.